Good afternoon, Lisa Homa here. Hope you're having a great day. We're on to neuro. The objectives for this lecture today are to demonstrate beginning level skill in the techniques of physical exam, and we're going to go through each step and where we should focus in the neuro system. Inspection, palpation, percussion, and auscultation. And so how the lecture was arranged for you to understand assessment for the neuro system is basically, the sicker your patient is in neuro, you're going to dive in and perform more tests. If you're in an ambulatory setting or in an office setting, you're only going to do what is indicated at that time for that patient. But I wanted to include all the information, so if you're also in acute care, you would be able to utilize this information to implement a neuro assessment no matter where your practice setting is. So every comprehensive neurologic assessment should start with in a certain order, and it should definitely start with mental status. There are certain elements that comprise the mental status. It's level of consciousness and mentation, pupils, vital signs, Glasgow Coma Scale, and the NIH Stroke Scale. We're not going to go through NIH Stroke Scale. That's something you have to be specifically trained, and it's more of an acute care type of assessment, which we're not going to go through here. Cranial nerves is the second piece that you must go through with a comprehensive assessment. The third is the sensation. We want to test the sensation system. And then the motor system, which is comprised of reflexes and cerebellar function. Whenever you see a patient, they're admitted, or if we're talking acute care, you always want to do the comprehensive assessment as much as you're able to based on the priorities that are happening with the patient. And then you can come back to do focused assessments in between. But you always want to start out knowing full well exactly what you're coming into before you move any further. So these are some of the questions you want to ask your patient under the subjective data category. So as far as headaches, you want to ask the patient, have you had any unusual headaches, something they've never experienced before? Or have you had headaches increase in frequency? And what are we driving at? Why do we care about headaches? Well, headaches could just be a person who has a history of migraine headaches, and it could be a hormonal change or it could be related to diet, but it also could be brain tumor, it could be aneurysm, it could be other really big things. So it's an important question. Headaches are often precede something really bad happening. As far as head injury, you want to know, did the patient ever experience a head injury? And that could, remember, concussion is head injury. So you want to ask when it happened and all the details about it if the patient can tell you about it. Dizziness and vertigo is also important. Many patients experience this with aneurysms. They experience it with brain tumor. So you want to ask the question, do you ever get lightheaded? Do you ever feel dizzy? Do you ever have a swimming sensation? Or do you lie down and you have the room spinning around you, which is a true vertigo? You want to know about seizure history. People have a giant brain tumor. They have surgery to have it removed, and then they have seizures that plague them the rest of their life because of irritation from taking out the tumor. So as far as seizures, you have to think safety first. So you want to know how often they have seizures. Are they on medication for it? Are they controlled? Are they not controlled? Because a lot of people cannot drive because they have uncontrolled seizures and they're a hazard or risk to others. For tremors, we look for neurologic disease, pathology, and you want to know if they have fine or coarse tremors. A way to find out, so if they have coarse, you can obviously see them, right? Their hands are going to be moving around. How do you tell if someone has a fine tremor? They may feel it, but you may not see it. So one quick way of doing that is to put a piece of paper on the back of their hand and to see if it moves the paper. And then weakness, we're going to do a lot of tests to test weakness, but sometimes you will notice it just as the patient walks in the room. You'll see it immediately. Also, along with weakness, does the patient move with coordination or are they not coordinated at all? Do they have any abnormal sensations like a paresthesia, which is an altered sensation that should not be there, any burning, tingling, anything like that? So I probably should have said this first, but let's talk about the preparation that you need for your neuro exam. So you should work on screening. So again, that's testing for disease or preventative maintenance. You want to make sure that you complete a full neurologic exam, and those are the 4 areas that I just mentioned. And then you want to come back for a focused exam or neurologic recheck, which is more important in the acute care setting. You wouldn't be doing that outpatient. Equipment needed is you absolutely need a pen light, you'll need a tongue blade, a cotton swab, a cotton ball, a tuning fork, a percussion hammer, and occasionally you'll need something for testing olfactory. But honestly, we don't really test olfactory unless it's something specific, like if we think the patient has a specific type of tumor or something of that nature. This is a little bit more geared towards acute care, but it is the single most important assessment that we do. The two things that a patient will precede almost every single time, unless they have an aneurysm rupture at the bedside or something of that, they're going to have a change in their level of consciousness. You're going to almost always see that first. And then mentation, they'll have a change there. And then let's talk specifically about how we assess mentation. Is the patient alert and awake enough to answer questions, right? Are they cognitively aware enough that they can answer the A and O times 4? And it is A and O times 4, not A and O times 3. It always makes me crazy when people say that. So you want to know, is the patient oriented to person, place, and time? And the fourth is context. And the killer question is, what brought you into the hospital today? And a lot of times patients will memorize those first 3 questions. They think they're being slick, and when you go to bring context in, they just can't do it. Let's go over the level of consciousness terminology. And this is kind of hard. Some patients, they wax and wane. So one minute they're one thing, and then the next minute they're another. But in general, you can see these patients degrade. So again, the sleepier a patient is, the sicker they are, the more at risk, and it shows that something really bad is happening. A sleepy neuro patient is not a good thing. So fully conscious is just how we are, hopefully, except if you're sleeping through this lecture. We want them to be alert. That means that I can ask them any question, they're responsive, they're looking at you when you talk to them. Lethargy is the patient is drowsy, but they awaken pretty easily. Sometimes we have to stimulate them, and remember, neuro nurses are really mean. We do terrible things to wake patients up. Will they follow commands? And obtunded is the patient's really difficult to arouse and needs constant stimulation. It's like, Mr. Smith, if you don't open your eyes for me, I am going to take this pen and ram this into your nail beds to make you wake up. That's kind of what that is like. They will constantly be drifting back to sleep in between things. And that's not the kind of patient you want to take a look at. They are not doing well. A stuporous patient requires them, and we don't do sternal rubs anymore, although every once in a while I see a physician who does a sternal rub and I almost fall over when they're doing. You should not do that anymore. But they'll do some really terrible pinching on people. Have you ever pinched your tricep? They'll pinch triceps. They'll pinch the skin on your chest, which is really painful, especially if it's like a man doing it on your chest. That would be terrible. Stuporous is the patient arouses to vigorous and continuous stimulation, and it requires painful or noxious stimuli in order to get that patient to wake up. So that's when we're really hurting them. What I do for neuro checks all the time on my patients is I'll take the cap off of an 18 gauge needle and I'll use the cap for my assessment. So when I go to find out if the patient's able to move certain things, I'll go right to their nail bed, take the plastic cap and put it on that part from where your nail goes into your cuticle, and you press on there and that gets them moving. Because you have to know, if it's a matter of taking them back to the OR or whatever it is, you have to know where that patient is at every moment in time. And then comatose is the patient, no matter what you do, you try to beat them up to get them to respond, they won't do it. And that's a really, really bad sign. That is an emergency. And then stroke patients, not going to really mention much about it again. What I said at the beginning is probably all you need to know. There is a certificate that comes with it. If you work in a stroke unit, in interventional radiology, or any of those places, you will have to maintain NIH stroke scale certification. And I think that's every 2 years. There's a certain amount of hours that come along with that. And then Glasgow Coma Scale, we're going to talk about that in a second. So it's based on 3 responses. We usually use this in acute care. You're not going to be using this it's, can the patient open their eyes? How do they respond to you, their motor system, and then are they able to verbally respond? If the patient is intubated on a ventilator, they get a 1 with a T saying for tube, because they're not going to be able to respond to you because they have a tube down their airway blocking their vocal cords from talking to you. Patient receives best score for best response in each area. 15 is like you and I, hopefully, walking around, walking and talking and chewing gum. Anything less than that, usually less than 8 indicates coma. So if you have a GCS of 8 or less, then your patient does not look good coming in. And then assessing speech and hearing. This is really important, and I've heard people say this word different every time, so I'm just going to mention it both ways. It's either dysphagia or dysphagia. You want to know, does the patient have any problem swallowing? That kind of goes along with these systems. There are certain brain tumors that sit right in the hearing pathway, an acoustic neuroma, so you want to know about the patient's speech and their hearing. Is their speech clear and appropriate? Sometimes I can just say from working night shift for many, many years, I never drink enough fluids on night shift. I can almost have garbled speech by morning, so your patient could be dehydrated and their mouth could be dry and they could sound a little garbled or slurred, and that doesn't actually mean. So you want to be sure that if you're saying it's slurred or garbled, that there is a real valid reasoning behind that. Is your patient talking inappropriately? Do they have word salad? Do they have any of those things? And aphasia. So let me talk about aphasia for a second. If a patient has damage to the Wernicke's area, then they're unable to receive communication. Patients with Wernicke implications, they have receptive aphasia. So the person knows something is being communicated to them, but they cannot understand what's being communicated. If a patient has injury or something happened to the Broca's area, that's the area responsible for giving communication. Then the patient has expressive aphasia. So the patient knows what they want to say, but they just can't get it out. Sometimes with a left MCA stroke is the worst stroke that you could have. Well, if you're right-handed, it's the worst stroke you can have, because many of those patients, it wipes out the Broca's area and the Wernicke's area, and they end up with global aphasia, meaning they have expressive and receptive aphasia. It doesn't have to be permanent. Those things can improve through rehabilitation. It would obviously better if the patient went to neuro intervention and they could remove the clot, let's say if that happened during a stroke. But if that's not possible, those areas can be rehabbed with some pretty intensive rehab. Do they use hearing aids, or has their hearing gotten worse? Because again, you worry about permanent loss with something like a brain tumor, an acoustic neuroma. Before I explain cranial nerves, I'm going to get a little anatomy on you here for a second, just to try to clarify some of these areas for you. So the spinal cord is arranged into horns. If you take the spinal cord and you slice it straight across from the top to bottom, it'll look like a butterfly with wings, right? That's called a horn. So if you feel something on the right side of your body, the nerve will travel in through the horn, cross to the other side, and go up to the brain, and there will be a synapse in that area that captures that stimuli. So think about this. Sensation happens in the body along two pathways. Maybe how you get to and from work every day, there's two different routes that you can take to get home. And our body, our neurosystem has the same thing. There's two pathways that the brain can use to get sensations from places from like the feet up to the brain or from the arm up to the brain. The first pathway is the spinal thalamic tract, and the other is the posterior columnar. And in our motor assessment, we're going to test both of those areas. So the spinal thalamic tract is responsible for pain, temperature, crude and light touch, and it crosses sides. So it does cross one of those horns, just like we started to talk about. The posterior columnar tract, it does not cross sides. It stays on the same side. It's responsible for positions. So let's say close your eyes, hold your hand up, move your hand around. Did you know that maybe your one hand was higher than the other? You can't say how you knew, you just knew, right? That's the posterior columnar tract. How would we test position sense? So put your hand on the table, tap it. If you feel vibrations, that's the postcolumnar system. It gives you the ability to discriminate touch. Let's say you close your eyes, you're in lecture, you close your eyes, you're taking notes, and then you know somewhere along the way you were writing with a pen on paper, right? Old school. And you know there's a pen down there. Well, how did you know that was actually a pen? If I reached down there, how'd you know it was a pen? How did you know that was paper? Well, some of it is you had a little visual preview, but in general, that's your posterior columnar telling you or showing you that. Now, for the spinal cord itself, let's talk about motor pathways for just a second. We have the corticospinal tract. It's also called the pyramidal tract, if you've ever heard of that. This is part of the brain that looks like a pyramid, so it's called the pyramidal tract. All go through the medulla's pyramid, so we have both crossed and uncrossed pathways. This is what is responsible for finer body movements. So to test this, do something simple. Take your finger and just point it to your thumb. This is called the pincer grasp. This is a good way to test fine motor movements. Crude movements occur through the extrapyramidal tract. They go around the medulla's pyramid, and things like a crude movement would be walking. So for upper and lower motor neurons, we see arms versus legs, walking, and then upper body. We have three different kinds of reflexes: deep tendon reflexes, superficial reflexes, and visceral reflexes. So assessment of the cranial nerve, we test them together in certain ways based on their structure or function. Cranial nerve number 1, olfactory, many times for a regular routine neuro exam, we will not be testing an olfactory test. Cranial nerve number 2, the optic nerve, and we'll use a Snellen chart, test visual fields, and 3 is the oculomotor, cranial nerve number 3. So we'll be testing that, and we have a couple slides to show on how to appropriately test those. You want to check for corneal reflexes, facial nerve, vestibulocochlear. You're going to test that. Along with that, you're going to do a Weber and a Rhine or Rinna. Some people have heard it pronounced both ways. And then the gag reflex, we'll work on testing that. In the course, there are videos that will show you how to perform each one of these tests so that if you are unfamiliar with them, you can learn them in the course. Here's just a mnemonic to help you remember the order in which the cranial nerves sit. This is probably very familiar from nursing school. And then let's move on to pupils. So pupils are specific to the cranial nerve number 3, oculomotor response. We want to know about size. Are the pupils equal, round, and reactive? A lot of this stuff should be familiar for you already. We want to know, is the size measured in millimeters? Drugs influence this. Patient's neurostatus influences this. A lot of hospitals have gone to pupillometers, if that's a new thing for you, because subjectively, there's a lot of variation between providers in gauging how big or wide or the millimeter. Most places have gone to quantitative pupillometry. Then you want to know, is a pupil sluggish? Is it brisk? Is it non-reactive? Sluggish, non-reactive, not good. Consensual reaction of opposite pupil at the same time. To find out if a pupil is consensual, you're going to hold the flashlight, your pen light, over. Let's say you were testing the right eye. You're going to keep the flashlight over the right eye, but you're going to slightly move it in the direction of the left eye, and you're going to be looking at the left eye to see if it reacts on the opposite side. I don't have accommodation on here, but all accommodation is if you focus on something close enough, your pupils will constrict. That's normal. And then here is a picture that shows exactly what your pupils should look like. If you look at the abnormal side, the one in the middle, that's actually called ovoid, an ovoid pupil. It looks oval shaped. And we know that's really bad. That's a sign of increasing intracranial pressure. It can precede a neurochange, a significant neurochange. It's not a good sign when you see that in patients. And then the worst sign of all is, I love like those healthcare shows where they talk about, yes, the patient's pupils are fixed and dilated. Yes, that is a really bad sign. That is a sign of a dead patient. Usually it means impending herniation. If it hasn't already happened, it's in the process of happening. It is an absolute emergency when you see that. And then here is how it should look with the light. So it should respond briskly, like immediately. The second the light starts moving towards the pupil, you should see it moving. If it is sluggish, that's also not a good sign. That's a sign of an injury or something else. If it's non-reactive, that's an even worse sign. And then pupillary changes, accommodation is by holding your finger 4 to 6 inches from the client's nose and then pull it out to 18 inches. Again, it will constrict. So the pupil should be equal, round, reactive to light, and they should accommodate. And then cranial nerve number 2 is the Snellen test. They have these cute little Snellen charts. You can have a pocket one. Impaired visual fields can be stroke, TIA, could be brain tumor. Cranial nerves 3, 4, and 6 are often done together. So use inspection and then ocular alignment with this. So have the patient follow your fingers with their eyes. And again, I have a video on how you test all the cranial nerves in the course. So that would be easier than me just explaining it to you. Side to side, up and down in an H pattern, and then look for failure of movements. And nystagmus is just an extra movement. Nystagmus is just an involuntary eye movement which can cause the eye to rapidly move from side to side or slightly blur their vision. It can have causes that aren't necessarily due to underlying disease. It can happen in an injury as a kid. People could have a family history of nystagmus. It could be for a lot of reasons. So it doesn't have to mean that it's pathological, but oftentimes it does. And then cranial nerve 5 and 7 are often tested together. Again, sensory, corneal, reflexes, and motor. So to test for pain, touch, and temperature, gently touch the patient's face with a clean safety pin. Whew, that just sounds bad. And then hot and cold objects. For corneal reflexes, that's usually an easy one. You could just, in an awake patient, if you start coming at them with a cotton ball or a Q-tip towards their eyeball, believe me, they are going to blink and come right at you. This is more so for somebody in more of a comatose state or someone who's waking up, and you would take like a cotton ball, a Q-tip, and start moving it directly towards the eye. People who are in a deep coma, they will not see you, they won't flinch, nothing. And then to test motor function, you want to have the patient clench their teeth and move their jaw from side to side. The vestibulocochlear nerve. So you want to do the whisper test. This is on your comprehensive assessment. So you want to make sure that you understand how to do that. So you want to whisper in the patient's ear, have them repeat what you said. If deafness is suspected, you want to perform, some people say Rhine, the Weber's test. And there is a video on the course to show you how to do those. We're not going to do it here. And then cranial nerves 9 and 10. This is where we are impaired. If patients have injury to this, when a patient wakes up from anesthesia, is you want to test to make sure that they have their swallow. They're not going to aspirate when you give like liquids. You want to ask the patient to open their mouth, say ah, when you can use a tongue depressor. You want to observe the movement of the soft palate and the uvula, and they should rise medially. In order to do a cranial nerve assessment, your patients have to be cooperative. If you have an uncooperative patient or somebody in a coma, you're not going to be able to test the cranial nerves. It's 11 and 12. Accessory spinal nerve, have patients shrug their shoulders or turn their head from side to side. And then cranial nerve 12 controls their movement of their tongue. This should be a good one for them. They want to stick their tongue out and do na to you. And then evaluating sensation. Okay, so a good way to test the sensory, there's a couple things you can do. So let's say, for example, testing the hand is a good place to do it. And let me just explain why. So how many nerves innervate the hand? We know we have the radial nerve, the median nerve, and the ulnar nerve, right? So if I want to test for pain, I can do light touch with a Q-tip or a cotton swab on 3 places of the hand, right? Put the Q-tip on different parts of the hand and say, what do you feel? So there are 5 tests that you should do to test sensation. You only need to do 5 of them though. So for tactile discrimination, you could put a few objects in their hand like a button or a paper clip and see if they can identify what that is. You could also have them close their eyes and take their hand and you write alphabet letters on their hand. And that's called graphesthesia. So they can feel what you write. Now there's a couple letters that are kind of hard to tell apart, like a P and an O, so don't use those. I would use capital letters, don't use lowercase letters because that just makes it harder. But you can use tactile discrimination, graphesthesia. You can use 2-point discrimination, which is 2 objects at the same time, and you want to keep getting closer and closer to them until they only feel one. So basically, you measure that distance of where they can now feel the 2 sensations as one, and that gives them a distance, the 2-point distance. You can also do extinction. So try to have them touch them on like their left arm and then their right arm, and their left arm and their right arm. Some people can feel it, but some people cannot. You could have the patient close their eyes and touch at 2 different points at the same time and tell me where those 2 points are. Like, for example, the trunk and the shoulder or the hand and the arm, and see if they can feel it, if they feel it as the same thing or 2 separate points. You could also do point location, which is the 5th test. You can touch them somewhere on their body and they have to point it out. You get to choose which of the 5, but remember you have to do 2 of them to evaluate their sensation. Here are the tactile sensation. You can test temperature, you can do pain, you can do vibratory sensation, you can do tactile discrimination. And again, for testing motor, you're seeing a theme here. Patients have to be awake and cooperative, or most of these tests aren't going to work. So it's important to test the patient on both sides of the body, so bilaterally. Let's look at the 5 different areas. So you want to make sure that the patient able to follow commands. Do they have muscle tone? A sign of atrophy means something. So if a patient is atrophied in an area, that's important to note. You want to do the strength test, so that would be muscle strength. We want to test cerebellar function, which is coordination. So one thing I want to mention about the cerebellar, while you are assessing the cerebellar function, cerebellar disease manifests on the same side of the lesion. So if the patient is having deficits on the right side of the body, then there's a very good chance that they have a right lesion in their cerebellum. You can test tandem walking, which is walking 1 foot in front of the other, very close to each other. Again, there's a video for that to show you how to do it. You'll want to test the romberg, and you need to know how to demonstrate a romberg for your comprehensive assessment. You want to close your eyes, put your feet together, but make sure the patient is safe. Don't just let them fall over if their cerebellum is off. You want the patient to stay in that position for about 20 seconds. If they move, if they have to open their eyes, if they become unsteady, they fail. You can test their coordination to get at their cerebellar function, which is rapidly alternating movements. And you can do that in two different ways that you've probably seen. I think neurosurgeons do the most, the finger to thumb. And there's a video on the course to show you also how to do that. This sounds really silly, but pronation and supination test is also really important. Just take your hands and lie them flat like on your thigh, and then have them just do back of the hand, then front of the hand, back of the hand. You just have them flipping back and forth. Patients can't do that. You'd be surprised they're unable to do it. So if they're unable to do that, there is some big gigantic word. It is called dyadicokinesis for those issues. And then if you have somebody who's in a comatose state, or near comatose, they have a Glasgow coma, definitely less than 8. You'll notice abnormal posturing, so that you'll see a decorticate movement, and decerebrate is even worse. And then let's get to reflexes. So let's talk about superficial reflexes for a second. So it's a superficial stimulus will cause a reaction. It's pretty simple. An example of that would be checking a corneal reflex. It'll make you blink when you try to move something towards the patient's eye. Or checking an abdominal reflex. Watching a person tense up when you tickle their muscles in their abdomen, that is a superficial reflex check. And for deep tendon reflexes, these are all the deep tendon reflexes you should be familiar with: the biceps, triceps, patellar, Achilles, and the plantar. So essentially, by checking a deep tendon reflex, a tendon is stretched, it'll cause the muscle to contract. It's not listed here, but just because I mentioned it earlier in the lecture, visceral reflexes are reflexes that come from a much deeper level. And one of those would be like checking a pupil. In order to have a muscle or motor movement, we need to have a sensory nerve, 2 synapses, a motor nerve, and a competent muscle. So we need to have 4 things intact in order to see deep tendon reflex. Here is how to assess the deep tendon reflexes. Again, talking about grading the reflex from 0 to 5. I do have listed how you test all of them here, but it's a lot easier probably to see them by a video, which doesn't pertain to a lot of you, but I just wanted to have it here just in case. So you would be assessing for motor response. And the thing that's not good about this slide is sternal rubs or sternal pressure anymore. And then evaluating cerebellar, we already talked about that pretty in depth, so I'm just going to keep moving. And then this is the description on exactly how you do a romberg, which again, there are videos in the course, which is probably easier, but I have it here in case you want to read about it. And then vital signs are really critical. So this is more for the acute care, and these are late findings. So by the time the patient ends up having Cushing's triad, they're dead. And you can see exactly when that patient is herniating. If you see Cushing's triad, the brain is about to come down through the foramen magnum, and that patient is herniating. It's already game over. And then abnormal posturing. If you're somebody who works in another specialty, you may have never ever seen this, but this is exactly what it looks like in an ICU setting. It would be in the comatose patient with the GCS less than 8. And then brainstem reflexes, not tested in your course, but I just wanted to mention it. All this stuff is bad. When all this stuff is going on, if you're testing doll's eyes and vestibular reflex, you're talking about finding out if your patient is brain dead, and they are dead. So these are not good things to see if this is happening. They'll do flow studies, they'll be testing these reflexes, and then they'll be assessing those organs for donation. And then some things about your charting. I'm not going to spend much time here, but this is a nice way that you should be charting your notes, and we'll just keep going. Again, this is a nice way to document your mental status and what you had. Be very descriptive. The one way to keep yourself out of court is to make sure that you describe exactly what you see. Don't be biased. Make sure you describe what you saw in your assessment explicitly. And here's one last thing. Again, you can look at this another time. And that's it for me. Have a great day.